Hello, good morning everybody. I'm Janatul Firdaus, PGY 2 Neurology resident. Welcome to Stroke Test Review. Today my presentation will be MCA infraction. So chief complaint, right-sided weakness and speaking difficulty. The stroke code, that was the stroke code, was activated by EMS. So 72 years old male with the unknown past medical history presented to the emergency room with the right-sided weakness and speaking difficulty. According to EMS, the onset was 2 p.m. He was watching TV and sister suddenly noticed like he's having difficulty speaking and right-sided weakness. They called EMS. Upon arrival to the emergency room, stroke code was activated 3:40 and neurology team evaluated 3:45. So that means the patient arrived to ER 1 hour 40 minutes is within the TPA window period. After reviewing the indication and contraindication, we gave TPA. The past medical history unknown because the patient didn't go to the physician, never. He didn't have any primary physician. That morning, he was feeling kind of cold and coughing, so sister gave his medication, doxycycline and cough syrup. Review of the system, unable to obtain because patient presented with the global aphasia. Social history, the active smoker. On physical examination, so vital was blood pressure was 171/79, heart rate 120, and respiratory rate 30. Oxygen saturation 97% on 2-liter nasal cannula. Lungs was clear. And neurological examination was limited because patient was not able to cooperate. He presented with the global aphasia. That means he cannot speak and he cannot understand. So pupil was reactive and equal and reactive bilaterally. Left gaze preference, like he was looking like this. That's left gaze preference. And questionable visual defect because we are not sure the patient is having visual defect or not at that time. Global aphasia, mild right facial droop and right-sided weakness. Motor strength was upper and lower extremity 0 out of 5. And right-sided was pretty good strength 4+. Reflexes 2+ throughout and symmetric. So CT head was done. It's not showing the picture. No? It's not coming? Just coming. I'm sorry. Yeah. And the CT didn't show up. So CT scan did not show any hemorrhage, and after reviewing the indication, contraindication, we gave TPA. And then next, the MRI was done. You can see like on the DWI and ADC map, usually we use for stroke, and it shows the hyper-intense lesion on the left parietal area. One more slide, one more, next one. And then it shows this, like, it's almost like most of the cortical area. It's involved in the left frontoparietal mainly. And it's the ADC map is also like hypo-intense, like black color, and this side is a white color. Other lab findings, the hemoglobin A1C was 6.6 and the echocardiogram unremarkable. Carotid ultrasound shows the complete block of the left ICA and significant occlusion of the right ICA and CCA. So our impression was acute ischemic infarction, the left MCA, likely it's a thrombosis from embolic phenomenon from artery to artery. So the middle cerebral artery, actually I wanted to show here like the branches of the middle cerebral artery and from where the middle cerebral artery comes. In the front it says the like arch of the aorta, then common carotid artery, and it goes the external carotid artery and internal carotid artery. When internal carotid artery goes up intracranially, it gives two branches. One is the MCA branch, middle cerebral artery, and the anterocerebral artery. Middle cerebral artery has several branches. One is the deep penetrating or lenticulostriatal branch, and then the cortical branch. Can you come next slide? So deep penetrating branch would be pointed to, let's see. This is the lenticulostriatal branch. It supplies the internal capsule, mainly the basal ganglia, globus pallidus. So it supplies the internal capsules, chordae nucleus, putamen, and outer pallidus. And cortical area, it shows here the superior cortical. This is called the superior division of the cortical area, and this is the inferior division. So superior division actually supplies the most of the, this is the lateral surface of the brain. So most of the lateral surface is the frontal parietal, part of the occipital and temporal. And here, except the superior one stem, this is the yellow color, is supplied by anterocerebral artery, and blue color is supplied by the posterior artery. Now, the signs symptoms of the MCS stroke. Signs symptoms of the MCS stroke, it depends like where is the infarction and how severe the blockage is. So, if it's in the complete block, like complete MCA, so it's present with the contralateral hemiparesis. That means if it's the left MCA presented with the right hemiparesis. So contralateral hemiplasia, contralateral hemianesthesia, global aphasia. Ipsilateral gaze preference, and contralateral homonymous hemianopia. If the dominant hemisphere involved, that's the hemineglect and constructional apraxia. If it's involved in the M1 segment that I mentioned on the previous slide, on the deep part here, so that causes, it's the ischemia of the internal capsule that produce pure motor or the sensory motor symptoms contralateral to the site of the lesion. If the ischemia involved in the putamen pallidus, predominantly the Parkinsonian syndrome. If the cortical branch involved, if it's in the superior division here, so it's present with the weakness of the face and arm with the Broca's aphasia. That means patient cannot express, cannot talk. And some cases the sensory involvement. If the inferior division involved, and if it's in the dominant hemisphere, would be the Wernicke aphasia. That means the patient will not be able to understand. Contralateral homonymous superior chordinopia without weakness. If it's the non-dominant hemisphere involved, that means hemispatial neglect or the spatial agnosia without weakness. So what is the neglect? Neglect, usually patient is unaware about their deficit, especially on the left side, because if it's the dominant hemisphere on the right side. Sometimes they put the makeup on the half of the face and they don't put, because they don't know like this side, left side is exist. Shaping on the one side, other side doesn't shape. When you give the food, they will eat the half of the food and left half they will leave. When we tell them to draw the clock, they will draw like half of the clock, like 1 to 6, not the left side. So when they walk, they bump to the left side because they are not aware about that. Sometimes it's very difficult to differentiate from homonymous hemianopsia from the neglect, but if we see the homonymous hemianopsia, patient is aware about their deficit and they try to look like this, like no, I have this side is exist, but hemineglect, they're unaware about their deficit or their left side. Any questions? No? Okay. Thank you. It's very sure.
Good morning, everybody. I'm Dr. Prieto. I'm one of the residents, second year as well. Thank you for coming this morning. I know it's early and you also have a lot of things to do. If you have any questions, feel free to ask at any time. I'm going to talk about watershed infarcts, which is complements what Dr. Ferdows just talked about. This is a case that we had here in the hospital. A 73-year-old Filipino woman. She had a bilateral mastectomy, and she had two events of syncope. One 2 days after the surgery, where she was recovering, and then the morning that she presented with the symptoms. Around 9:30, she was noticed that she had facial droop, left-sided weakness, and moderate aphasia. So the stroke code was activated. A little bit later, because he didn't know what to do. The NIH stroke scale was 5. We did CT scan. The CT scan was negative for any bleeding or any mass. And also, when we repeated the labs, it showed that there was a drop from 13.5 to 0.7 to 7.5. So it kind of turned a yellow light in our heads. We had a large discussion with the family at that time, and the family initially wanted to give TPA. Since bilateral mastectomy is not an absolute contraindication because it's on top of a muscle, it's mostly connective tissue and subcutaneous tissue, and her blood pressure wasn't also an absolute contraindication, but it was relative contraindication, and when she was transferred to ICU, she decompensated. And she was resuscitated with fluids, and at that time the window was beyond 4.5 hours, so we decided not to give TPA. And the patient afterwards did well, but this is why we didn't give TPA on this patient. This is the MRI. I don't know if you can see here this area, little dot, and here. We see a small line. Can you see? Oh. And we cannot see very well with the lighting, but we see hypodense, hypointense signal in the APC, and this is diffusion with images. The impression on the MRI was compatible with a watershed infarct, and the patient didn't have much. Had a little bit of ischemic vessel disease on other images, but nothing like a vascular territory per se. When we we did a full stroke workup. She had a normal cardiac function, no thrombus in the heart, no abnormality in the mobility of the ventricle, and also we did a carotid ultrasound, which showed less than 50% of stenosis on the left ICA. So she did have already some changes in the carotid, but it wasn't a high-grade stenosis. And after reviewing the case, we concluded that this stroke was likely due to hypoperfusion, low blood pressure that caused a stroke. And how does it happen? The watershed infarcts are roughly the 10% of all the strokes. These infarcts occur in the end vessels. So if Dr. Ferdows explained that we have the MCA providing the cortical vessels and lenticular vessels. Some of these vessels are just end, like fingerless. They don't connect with another vessel. So when there's low blood pressure, they constrict, or there's no blood going through, and it causes a stroke. So some patients can have microemboli on these areas, which could be another mechanism of the watershed, which we'll see in a little bit. So in this image, I wanted to show, this is not the patient, but I want to show how the vasculature of the brain, it supplies throughout and has a smaller internal vascular endings. And there are two patterns of watershed infarct. One is cortical, and the other one is internal border zone. Cortical are the vessels that are in between the major vessels, like anterior cerebral artery, middle cerebral artery, posterior cerebral artery, and the internal border zone are the ones that are around the colonna radiata, around the ventricles, the ones that, the small vessels that we looked at in the previous presentation. So in this area we have the territory of anterior cerebral artery, middle cerebral artery, which is what we just reviewed with Dr. Firdaus. This is posterior cerebral artery. So what happens is that in these areas in between, it's like a gray zone. So vessels end and not always make connections among themselves because they're different from different origin, and these areas are more susceptible to embolic strokes and that come from the heart or sometimes arteries, and also from low blood pressure. And these are more susceptible areas. As I mentioned, the mechanism of this type of stroke is likely to hypoperfusion and embolization. In patients that have cardiac surgery, anybody who works in the CICU or OR, so you may be familiar with this, and you've seen probably a lot of patients that after heart surgery they end up having a stroke, and they didn't find any significant clot in the blockage in the carotids or any other problem with the heart. But when the heart stops and during surgery, could be little thrombi going to the brain, or it could be a dislodging of plaques from the aorta. So when the little clots reach this area, the body is not able to clear them up efficiently because there's no perfusion. Plus, on top, the patient has hypoperfusion during surgery because of low blood pressure. Then these areas suffer even more. Patients that have severe carotid artery disease, have a higher risk in these situations. The watershed infarcts occur in between these areas, in between the colors. And it depends of the location that will cause the symptoms. I just mentioned this is a distal field, like a single-light presentation. So let's see how they look. We sometimes as a team we just review them right in front of you, and just looking at like what is this? They're called watershed. What is that? No. So we have the internal border zone infarct. These are they tend to look like rosary-like. They'll tend to be like 3 millimeter or more, sometimes aligned in certain areas of the brain, following the areas that I just mentioned. So we can see them here more clearly. Like they're small, not always continuous, like here. And the external border zone infarct, we have different areas. It could be anterior, middle, or posterior. Anterior and middle have more typical pattern, and the symptoms are more classic or kind of always the same, depending on the area that they affect. The posterior ones can give a variety of symptoms depending on how the vessel has this, the distribution of the vessel on each person. So here we can see an external is in the area of between the middle cerebral artery and the anterior cerebral artery here. Unfortunately, the images are not seen well. The cortical border zone infarct can be bilateral, and if we see that they are bilateral, likely this was hemodynamic compromise on top of arterial insufficiency bilaterally. So we can see here in the posterior, you can see this wedge shape in between vascular territories, MCA, PCA, in between. We can also see here this wedge shaped like a little pie. So for these patients that have watershed infarcts, if the patient is in acute state and doesn't have any contraindications, treatment has to be decided depending on the patient, on each case. But usually we evaluate these patients that have, with Doppler ultrasound of the carotids. We can do, in some centers, we have CT perfusion or MRI perfusion studies. We can do SPECT or PET scan to look at the uptake and the activity and blood flow in the area. And all of these studies can help us to look at patients that are high risk as well. So if a patient has a TIA and has some changes like tiny little areas in the watershed zone, we can do perfusion studies and see if some other areas are also at risk, and that could be added to the workup and to do a full exam on this patient to prevent stroke. Any questions? Oh, never mind. Well, just as a conclusion, just to wrap up, patients the watershed infarct count of about more or less 10% of all the strokes. These infarcts occur in the areas of high susceptibility where there's like end vessel. So they're susceptible to low blood pressure, and patients that have carotid artery disease are also in high risk. And patients that undergo to cardiac surgery have a higher incidence. Any questions? Well, thank you very much. Have a nice day.
I have a question.
Yeah.
In terms of recovery between the watershed and the other type of stroke, is there any difference in how well they do after?
It depends of the type of how large the stroke is and the location. But every patient that has a stroke should have aggressive physical therapy, special therapy early on to improve the maximum the outcome.
Good morning, everyone. I'm here with language barrier PGY3. My case will be a little bit different because of the location of the stroke. So it can present with a different characteristic of the stroke. So my case is the 52 years old, right-handed Caucasian female. She presented to the hospital with left-sided numbness, including face, arm, and leg. She had a past medical history with diabetes, hypertension, coronary artery disease, and tobacco abuse. What happened is she woke up with the left-sided face, arm, and leg numbness. And that's pretty much what happened to her. She came to the hospital the next day. Because of that, the onset was, she woke up with a symptom, so we normally not give TPA because we don't know the onset. Okay. That was the reason that we mentioned before that TPA was not given because she woke up with the onset and onset was unknown. The renal system was unremarkable. She had no history of allergy. She had past medical history of diabetes, hypertension, CAD. She's tobacco abuse. No family history of stroke. Vital sign at first when we saw her, blood pressure was high, 180, 115. Other than that was unremarkable. Neurological exam, as I mentioned, everything normal except for the red color. So she had gaze evoked with tagmat on the left gaze, which means that when you look to the left, you have some beat like this move to the right. So you can see that what we call the gaze evoked. this tetanus to the left case. She had increased sensation on the left side of her face, including V1, V2, and V3. So it up here, middle part, and the lower part of her face. On the other system, she had mild dysmetria. Dysmetria means you have some kind of ataxia, cannot move, cannot ride to the target. So, for example, when you take a finger to nose test, patient will not be able to reach the target normally. So she had mild dysmetria on the right upper extremity. Sensory, she had decreased sensation on the left upper and lower extremity on the pinprick and temperature sensation. On gait, when I asked her to stand to sit upright, she trained to kind of fall to the right side, what we call the lateral torsion. Seems something like somebody pull her to the back. You will feel like that when she sit down. When she sit down, she'll be like this all the time. Reflex were normal. Blood sugar was 232, platelet was normal, other labs are unremarkable. So what we find on this patient, we have two problems. One is a gaze revolt, this tetanus on the left gaze with lateral torsion. The second problem is left-sided sensory loss, including face, arm, and legs. With these two problems, two symptoms, we localize the lesion that most likely the patient has what we call right lateral medullary syndrome. It's the stroke, small stroke that happens in the medulla, in the part of the brain. So that I'm going to talk about that a little bit later. So after we think about it, we did the MRI, and we found a very small stroke in the part of the brain stem over here. You can see. So when we show the picture for the stroke, we usually show two sets of the pictures. The left one is what we call EWI, the right one is what we call ADC. So it has to be, in the EWI it has to be bright, meaning the white color. In the ADC it has to be black in order to diagnose stroke. So it has to be white here and black here. In this area, you cannot see well in this one because of the light, but you can see the very small area over here that have the restricted diffusion. Indicate that the patient might have a stroke on the medulla. So the last impression is like lateral medullary division stroke. So I can't talk a little bit about brain stroke. It can be really expensive, but I will cut all the part that you might need to know. So brainstem, you know that we have the big brain like the cerebellum, we have the small brain or cerebella, we have the brainstem in this location. So brainstem consists of three parts: midbrain, pons, and medulla. It's located between the cerebellum and spinal cord. As you can see, again, this is the front surface of the brainstem. As you can, I mentioned before, this is the big brain, right? This is the brainstem, and this is the cerebellum. The first two cases we discussed about the stroke that happened to the big brain. But this time we had a case that present with the brainstem stroke. So again, I just want to show in different view. We have the midbrain here, pons, and medulla. In the brainstem, there are a lot of structures inside. That's why even small stroke can cause a lot of symptoms. This is the cranial nerve nucleus that are in the brainstem. I'm not going to go into detail, but you have to have some idea that in the brainstem there are a lot of nucleus that contain the cranial nerve nucleus. When you have stroke in different locations, it can cause different symptoms. Okay? As an example, like cranial nerve 5, cranial nerve 6, this area. All our case is around in medulla, this area. Brainstem circulation. On the first two cases, we discussed about what we call anterior circulation. So basically, the posterior circulation, the main branch coming from the vertebral artery here, this one. And this report, I will talk a little bit more later on. But the first two cases we discussed that confirm the internal carotid artery, this one. So this is again easier to see. So the posterior circulation is this one that we're going to talk about. But the first two cases was this one, what we call anterior circulation. Okay. So brainstem circulation basically get the blood supply from the posterior circulation. So starting from the two vertebral artery here, they come together and form what we call the basilar artery, and then they cause what we call posterior cerebral artery. These two branches, and on the way here you have the small branch. This one is pica. We call it pica, the posterior inferior cerebral artery, cerebral artery. We have the anterior inferior cerebral artery, and the pontine branch, small branch here, and the SCA, superior cerebral artery. So this is the summary of the posterior circulation. So the first one, the vertebral artery branches, and most common that we find the stroke case caused by the posterior inferior cerebral artery infarct, I mean the thrombosis. The next branches from the basilar artery that consists of anterior, I mean what we call AICA, AICA, and then SCA, what we call superior cerebral artery that we call in short the SCA. And then the next branch is posterior cerebral artery that have the branches consists of perforate branches, thalamo-geniculate branches. So if I talk about the brainstem stroke, it will be like 1 to 2 hours. So I would just give a little bit of idea about the medulla lesions. So as I mentioned before, we have the midbrain, horn, and medulla. Right? On our case, she presents to the hospital with the right medullary syndrome, meaning that the stroke happened in the medulla. I will talk about the medial medullary syndrome and lateral medullary syndrome a little bit. So in medial medullary syndrome, it's caused by the problem with the artery we call anterior spinal artery syndrome. In this part, as you can see, this is the brainstem structure is in the medulla. You can see there are a lot of nucleus in here. There are a lot of plaques that consist of that come from the cortical. So even the small area of the stroke can cause a lot of symptoms. So in medial medullary syndrome, it usually affects in the medial part of the medulla. In this area, they consist of the medial lemniscus, and also pyramidal and rail nerve. So as you can see that it can cause the weakness on the contralateral side. And we have medial lemniscus problem, we have the contralateral loss of vibration and tactile sensation. Hypoglossal nucleus can cause an ipsilateral flaccid of the tongue movement. I mean, it's a little bit too into detail, but that's what to give an idea what's going on if you have stroke in the brainstem. On our case, is what we call lateral medullary syndrome. It's caused by the lesion in the pica artery. In this area, actually, it has more nucleus compared to the medial medullary syndrome. Go back to the same picture. The lateral medullary syndrome will be affected in this location. The most common thing that we usually find patient is they will come with you see this red one. Red one is spinothalamic tract. So the patient will come with contralateral decreased sensation on the contralateral side. Contralateral means a different side to the lesion. For example, you have the lesion on the right side of the brainstem, you will have left-sided numbness. Other thing that can involve is this area, inferior cerebellar peduncle. You can see that it involves a little bit in the anterior, in this part. So cerebellar, you know, what we call small brain, it controls the balance. So patients with this syndrome can come with the balance problem, ataxia, they cannot walk normally. Other part is it consists of reticular nuclei. That's why we found this tagus from this patient. Consists of the nuclear ambiguous of cranial nerve 9, 10, and 11. So patient can come with problem swallowing. It also consists of the descending sympathetic tract. So we usually check the pupil reaction as well. If the patient has some problem with involved sympathetic tract in this kind of case. As already mentioned. So I know it's a little bit difficult to understand, but a lot of nucleus are in the brainstem. And what I would like you guys to know is there are two things that I would like you guys to take home. The first one, stroke can affect various structures, as we can see in the first two cases, caused by in the big brain. And also small stroke can cause different neurological symptoms depending on where the location of the stroke. So patient have very severe symptoms doesn't mean that stroke is really big. It can be very small, like the stroke are in the brainstem. That pretty much I would like to give a message from this presentation. That's it. Any questions?
Good morning, I'm Pinyak Kim, PGY4 resident in neurology. I'm going to talk about progressive worsening in the lacuna stroke patient. So this is a chief complaint patient came with sudden onset dysarthria and the right-sided weakness. So she's a 55-year-old right-handed Hispanic woman presented with sudden onset dysarthria and right-handed crisis. On January 3rd this year, around 7 p.m., she was at home. She developed sudden onset of this symptom of slurred speech while having a dinner with family members. They witnessed it, and she just went to bed earlier than usual to take a rest. She did not go to hospital. She just didn't think there was a real something. Next morning, her symptom persisted, and she was brought to the ER finally. And at that time, she had no problem ambulating at that time. In the ER, she developed sudden onset right-sided weakness involving face, arm, and leg, and she was still able to move it, and she was still able to walk. Sensation was normal, and the ER note that time documented that her weakness was 4/5, and stroke code was not initiated because the onset of this arteria was more than 3 hours. It was out of window period at that time. Her weakness progressed over next 24 hours, and the next morning, she was unable to move her right arm and leg at all, and her slurred speech was even worse. And that time she denied any headache, dizziness, nausea, or diplopia. Past medical history has hypertension and dyslipidemia, and she did not take any medication for 6 months because of the financial issues. And social history, she's a passive smoker and no other drugs or anything. Physical exam, vital sign, initial vital sign was blood pressure was very high, 200 over 130, otherwise it was stable. And on neurological exam, mental status was awake and alert, normal. And the cranial nerve showed a right upper motor neurotype of facial weakness, sparing the forehead or wrinkling. And the sensor was normal. And the motor exam, as you can see, right side was 0. She was not able to move anything. And the Bobby scale was positive going up on the right side. So initial CAT scan was done the second day. There's small hypodensity on the left side here. It's very subtle. And this is MRI obtained on the same day. As you can see, this is a diffusion rate image, WI, ADC, a fair diffusion coefficient. So we have two images, bright here, and this is dark here. So she had stroke on the left side of the brain, in the deep brain. So our impression was acute ischemic infarct, and it was a lacunar infarct involving the area of the left ventricle straight arteries. So we're going to talk about this progressive nature of the stroke in this case. Lacuna stroke is a small deep infarct in the distal distribution of the penetrating vessel, and usually it's considered to have a fair outcome. But 20-30% of these patients get worse over the course and in hours or even days after the onset, and they're reaching eventually unexpectedly severe disability status. So this is a picture coronal view of the intracranial vessels. As you can see, this is the MCA vessel, like Dr. Brito talked earlier, and this is a large vessel. And there is a penetrating arteries, lenticular straight artery coming from MCA. This is a small vessel. So if you have a stroke in this area, they will give you lacuna infarct. If you get a stroke in this area, they will give you MCA infarct with a large area. Another picture showing you the usual typical areas of lacuna stroke. There's, in the deep brain, in opposed to the cortical lobar stroke, there's a small, you will get small area here or here in the basal ganglia or thalamus, you get the stroke. And another picture comparing, this is our patient, and this is the usual territorial ventricular straight artery. So this progressive lacuna stroke, we know so far the pathophysiology is not yet completely understood, and a predictor who's gonna get worse. There's no specific predictor identified yet, and there's a treatment neither evidence-based nor consensus-based guideline exists at this moment. So we have a very long way to go in this problem. And pathophysiology, more details, pathophysiology, there are two mechanisms in the lacuna infarct. Number one is lipohyolynosis, and then number two is atheroma. Number one is what we call small vessel disease, and number two is a large vessel disease. So number one, degenerative disorganization affecting the distal segment of penetrating arteries seated within the brain parenchyma. And number two, atheroma that usually affect the vessel proximally at its orifice, often in continuity with a plaque seated in the wall of the parent artery, means like a large vessel, like what we saw the MCA artery. So lacuna stroke secondary to atheroma seems to be more closely related to this progressive lacuna stroke, and it's well documented that this type of progressing lacuna stroke tends to be bigger than the usual small vessel stroke, small vessel disease related to lacuna stroke. And the possible explanation for this progressive nature, number one, maybe extension of the thrombus. It's just propagate perforating artery and occlude like arteries, so symptom progress. Number two is hemodynamic factors. Maybe it's orifice already partially occluded, so if blood pressure drops, maybe they get more ischemia. There's two possible explanations, but we don't know exactly what's going on. Predictor, like I mentioned, there's no specific predictor, but anything suggesting large vessel disease like atheroma, location of internal capsule, pons, or coronary radiata, and the presence of a risk factor linked to atheroma like hypertension, smoking, diabetes. That's the things that consistently recorded. Treatment, like I mentioned, there's nothing nothing proved at this point to prevent or stop the progression of this condition. And the goal appears difficult because there's nothing we identify exactly what's going on. So possible treatment options, even we don't have anything approved, but this is possible options. Aspirin, prevent thrombus formation and occur because of inhibition of platelet aggression by blockage of some prostaglandins. And there's one study in the 200 patients, they observed that being on aspirin at the stroke onset reduced by 97% the risk of worsening. And there's another study in 100 patients. They observed that no patient taking aspirin before stroke onset, they underwent progression. So further taking aspirin, nobody has this progressive disease. Another possible treatment option, glycoprotein 2B3A inhibitor. It can reduce thrombus growth and prevent thrombus reformation by comparative inhibition with fibrinogen. And there's two small studies in 35 patients. They use this medication, tirofiban, and they use the patient 96 hours after stroke onset in any stroke patient, and they observed that 21 patients with a lacunar stroke, they improved significantly with this treatment in only in lacunar stroke. There's another study with the epitibatide. This study is more specific to this progression. They use this medication 12 hours after the onset of the progression, and this progression occurred within 48 hours after stroke onset. And this medication, 42 patients had NIHSS score less than or equal to the pre-deterioration score, and 50% improved at least 1 point in motor item. So this can be the possible treatment option. And the other thing is that magnesium sulfate is helpful because it decreases neurotoxic effect of excitatory amino acid, mainly glutamate, and the pro-inflammatory cytokine and cell adhesion molecules. So there's a study, intravenous magnesium efficacy in stroke studies, the randomized, double-blind, placebo-controlled study. Basically, they just found no benefit to the large vessel disease with MCS stroke, but in the lacunar stroke, effect was greatest in patients presenting with lacunar syndrome, but there was no following study confirming this effect, so this is just still possible treatment. It's not proved yet. Anticoagulation treatment like heparin, Coumadin, is the most commonly used treatment aiming to stop ischemic stroke progression, but its efficacy in this setting remains largely unproven, and few small old control studies suggested some benefit, but recent studies failed to prove any effect, so it's not yet proved. And thrombolytic like TPA, we just have a few data exist about this treatment, so we don't use this in this setting. And induced hypertension, contradictory data reported, and both hypertension and hypotension have been associated with deterioration. So take-home message is lacunar stroke can progress in hours or in days, and neither evidence-based or consensus-based guidelines exist. However, anticoagulation, aspirin, glycoprotein 2B3A inhibitor, magnesium sulfate, it can be possible treatment options in the future. And there's no role of thrombolytic like TPA. Only for when I'm talking about progression, we still using TPA for the acute stroke, no matter what the etiology is. But for progression after the presenting after the stroke onset, we don't use. There's no role for the thrombolytic or induced hypertension in these cases. Any questions?
What happened to her and how did she?
She slowly improved, the speech improved, but she was still slurred. That's over 5 days after, she still slurred, but it was much better. She was able to eat, and she was understand that earlier at the beginning was like on the short talking like this, but later it's more clear. But strength-wise, she didn't get back any strength there. I didn't see any more later than that. Any other questions?
Any other question? Thank you, Sarah, for coordinating. And we discussed 4 different types of these disorders, MCA stroke and watershed. Also, Dr. Kim mentioned lacunar infarction and